I am Professor Neeraj Kumar Agrawal. I am Professor Endocrinology and Metabolism, Institute of Medical Sciences, Banaras Hindu University. Hello everybody. I am today discussing on fetal thyroid disorders, which is my topic for presentation. And with me is Dr. Gary Homer. He is from USA. Dr. Homer will tell about his interests.
Sure. My name is Gary Hammer. I'm a professor of medicine at the University of Michigan, where I direct our endocrine oncology program that specializes in endocrine cancers like thyroid cancer and adrenal tumors. I have talked today at this conference and yesterday on the evaluation of adrenal masses, and particularly about new treatments for adrenal cortical carcinoma. And we'll gladly talk about our work and ask each other a few questions about our interests.
Nice, Dr. Homer. So I would like to know about a few of the cases we have recently, and India being a country with less of money, so we want to have a very cheap alternatives to having costly tests. So in cases where we find a patient with a pheochromocytoma, can we do away with vanillin mandelic acid and not do metanephrine test?
Yes, we have not used metanephrines and we have not used VMA in some time in our studies. However, if you're convinced clinically of a pheochromocytoma and your VMA testing is sufficient with appropriate sensitivity and specificity, a VMA testing to rule in a pheochromocytoma is still fine. We would, of course, recommend the necessary alpha blockade, blocking down a patient to maintain blood pressure and fill intravascular volume prior to surgery. However,
so prior preparation is mandatory. It has to be done with every patient until we hand over the patient to the surgeons. So in that way, I think we can have a very cheap alternative to these tests. Sometimes they are costing us too much. Another aspect is that what we usually have the possibility of CT scans. So we usually have a Hounsfield scale, and which is
yes.
high, so we can have that ruling out of adrenoleukodystrophies, so that these masses or adrenal incidentalomas are easily diagnosable.
Yes. The non-contrast CT scan is probably the most economical and easiest approach to the evaluation of adrenal nodules in general, which are quite common. With 7% of the population of your country, in any country, having incidental findings on their adrenal glands, it's very important to rule out malignancy as efficiently as we can. And as you alluded to, on a non-contrast CT scan with Hounsfield units measuring less than 10, that defines a lipid-rich, benign adrenal cortical adenoma. It does not define the functionality of the tumor, and that still must be evaluated in terms of whether or not the tumor is making excessive hormone. But in terms of malignancy, you have ruled it out, and it is still the most economic way to do that. We occasionally do ultrasounds in children, as you know, but it's still not the ideal way to diagnose benignity and rule out malignancy. CT scan is best.
And one thing I came to know from your presentation, that the adrenal biopsy has to be very limited and it has to be carefully sought of.
I think this is very important. There are two messages about biopsying the adrenal and operating on the adrenal gland. One, most endocrinologists know that you never biopsy an adrenal tumor until you rule out a pheochromocytoma. But more importantly, you should never biopsy an adrenal gland, period, except under a couple of conditions. One, if a patient has an additional cancer and you need to decide whether or not the adrenal mass is the other cancer, lung cancer that has metastasized to the adrenal, or is a primary adrenal malignancy. In that case, and in that case only, we may biopsy the adrenal gland. And the second case would be a case of bilateral adrenal enlargement, where the diagnosis is in question, and you're trying to distinguish whether or not this is bilateral infection like TB, bilateral lymphoma, or a primary adrenal lesion. Those would be the only two reasons I can think of that a biopsy would be warranted. If you're concerned about a primary adrenal tumor, a solitary, unilateral adrenal tumor, if you're concerned enough, you should just take it out after you rule in or out functional excess. No biopsy. If you're concerned, you take it out. And I think that's a very important point. That's nice to share.
Another thing we usually notice that nowadays we are having a ambulatory blood pressure monitoring system, and if we use it in a patient who are suspected of pheochromocytoma, non-dippers have turned out to be a pheo, and dippers have been negative of pheo. What about your views on that?
I think not all pheochromocytomas, of course, present with hypertension that's picked up on a screening exam in the doctor's office. So I think certainly blood pressure monitoring at home has value in terms of picking up secondary causes of hypertension, which may be hyperaldosteronism, which is much more common. We think up to 5 to 10% of hypertensive patients actually have some degree of hyperaldosteronism, with pheochromocytomas being more rare. Nonetheless, these are good screening practices to bring to the attention to the endocrinologist uncontrolled hypertension that may indeed turn out to be something worrisome, such as a pheochromocytoma.
What are the new advances in treatment for adrenal carcinomas, which you can tell us?
Treatments for adrenal cortical carcinoma till recently are quite scarce. We still use mitotane, which, as you know, is a derivative of DDT, approved in 1959. We do use cytotoxic chemotherapies, cisplatin-based, as you know, for aggressive adrenal cancer. We are slower in development of new treatments than our sister cancers, thyroid cancer that you're well aware of, that I should ask you questions about in a moment. But the treatments for adrenal cancer are on the horizon, with genetics telling us that a subset of patients are particularly responsive to IGF inhibition. Another subset of patients should be responsive to inhibitors of the Wnt pathway, WNT. And another third, in the other third of patients, we hope, are amenable to immune therapy or cell cycle blockade. These are emerging therapies that we hope should come into the clinical arena in the next years to come. Now, in thyroid disease, it's a little different.
Yeah.
In thyroid disease, we are routinely biopsying almost all thyroid nodules. I'd like to know your practice on both the diagnosis of thyroid cancer, first of all, and perhaps the new treatments emerging for thyroid cancer that you're aware of in your practice.
In our practice, practically we are biopsying every case of say thyroid enlargements, and if at all it is multinodular, we try to find biopsy for every nodule which is less than more than 1 centimeter, so that we try to find out is there any carcinomas or microcarcinomas are there, and if it turns out to be Bethesda 3 or 4, it is more important to get a treatment, and the type of FNAC will decide the eventual outcome, because those patients who are having a papillary or follicular, they will have different outcome, and there have to be extensive neck dissections for lymph nodes.
In the United States, more and more of our endocrine oncology practices are using molecular classifiers on the biopsy to help determine aggressiveness of therapy and even diagnosis. Do you find that useful in your practice?
Right now, we are not using that because that's not yet extensively available, and that differentiation is not yet done by us in our patients. But mostly, still, we are using this surgery and radioiodine therapy.
Yes.
As a after the surgery, so that we remove all the possible tissues.
As with many cancers, although molecular diagnostics is helpful and gives us a nuanced view of the pathogenesis of cancer and helps us risk stratify, nothing beats looking under a microscope in many instances. Looking under a microscope is still the gold standard to help you define aggressiveness, and you're still going to engage in operations as you deem best fit clinically with radioactive iodine.
Yeah.
Now, what about pediatric disorders, pediatric thyroid disorders? I know this is a very interesting topic to you and near and dear to your interests.
Yeah, we are treating a large number of hypothyroid patients for growth disorders, and I will be talking on fetal thyroid disorders and those who have goiters detected in utero. They have to be treated because of the consequences of in postpartum therapy.
Fantastic. I would urge all attendants at the meeting to go to the talks later today, where my good colleague here will discuss thyroid management of pediatric diseases.
Thank you. Thank you.